Welcome to the Sound of Ideas from IdeaStream Public Media. I'm Stephanie Haney. Thanks for being with us today. Preeclampsia is a serious and sometimes deadly high blood pressure disorder that can show up during pregnancy. It's the leading cause of death among mothers and babies and affects about 1 in every 12 pregnancies, with certain groups at increased risk, including women over 35 and Black women. Rates of this pregnancy condition have climbed 25% over the past 2 decades, yet there is little research on its cause. Doctors often call for early delivery to treat this issue, which can lead to serious complications when preeclampsia is discovered weeks or even months before the baby's due date. Today, we're going to talk to mothers who have survived preeclampsia, and we'll talk to healthcare workers and advocates who are working to prevent the worst results for mothers and babies. Joining me for this conversation, in studio, we have certified diversity practitioner Tane Bolton. She's a senior director of strategy and engagement with Birthing Beautiful Communities and Full Spectrum Doula. Tane, welcome to the show.
Thank you so much.
Joining us by video, we have Dr. Kelly Gibson, division director of maternal fetal medicine at Metro Health. Dr. Gibson, welcome.
Thank you.
Also joining remotely, we have 2 mothers who experienced preeclampsia. Victoria McGinnis is joining us by video. Hi, Tori.
Hello.
And on the phone, we have Liz McCrae. Liz, welcome to the show.
Thanks, Stephanie.
If you have an experience with preeclampsia or questions for our guests, please give us a call. That number is 866-578-0903. You can also email us at soi@ideastream.org, or you can message us on Instagram. We're at The Sound of Ideas. Now, Dr. Gibson, let's start with what preeclampsia is and how it impacts the body.
A great question. Preeclampsia is a condition that only happens in pregnancy, and it's defined by high blood pressure. And in some cases, it can also affect other parts of the body. So primarily, we think about the lungs, the kidneys, the liver, or it can cause swelling around the brain and seizures, which is eclampsia. The high blood pressures can also cause very serious complications like strokes or heart attacks. And so all of these are things that in my work, we try very hard to catch signs early or stop if we see something developing.
Okay. Do we know anything about what causes preeclampsia?
It's a great question and one that has been researched for a long time, but we still don't have the exact cause of preeclampsia. We know that it only happens in pregnancy. So it is a condition that happens because of the interactions between different hormones from the placenta and the interaction with maternal blood vessels and other organs, but we don't have an exact cause.
And it can be potentially very serious, sometimes deadly, Dr. Gibson. Why is that? Deadly potentially for both mother and baby.
That's correct. And it again has to do with the high blood pressure, or what we call vasospasm. That's where your blood vessels, instead of kind of squeezing regularly to move the blood through, it starts to spasm, and that causes the blood pressure to go up. It also causes fluid to leak out into surrounding tissue. The most serious places for that are, again, around the brain. So swelling around the brain can lead to seizures, which can lead to severe consequences. Or that high blood pressure can lead to strokes. And that stroke is one of the leading causes of death from preeclampsia in patients who are pregnant or recently delivered.
Now, Tane, when we talk about how serious this is, we know preeclampsia is the leading cause of death for mothers and babies in the U.S. We also know the U.S. has the highest rate of maternal deaths compared to other wealthy countries. We also know that the rates of mortalities for Black people are 3 times compared to that of white people. So how do you work to address this as a doula and someone working to address discrimination in healthcare settings?
So it's a roundabout answer. One of the things that we do, we advocate for our clients. We also educate our clients. We educate them on the warning signs. We also educate them on actually coming home as well. So to look for the risk factors, the headaches, the pain inside, blurred vision. So all of those symptoms, we educate in pregnancy through our education, but we also, we have doulas who are like frontline in care. So they're constantly talking with their doulas. They're constantly in communication. And sometimes that trust, you'll report your symptom to your doula before you report to your provider because that trust is built.
How do you break through any barriers that might come with first-time pregnancies? For example, I could see how someone experiencing a first-time pregnancy might not know what their body's going to feel like, so they might be feeling things that are potentially risks for preeclampsia, but think that it might be normal for pregnancy. So how do you get past that barrier and let people know what they do need to pay attention to?
We have prenatal education classes, but it's also that relationship with your doula. It is talking about what it is, it's talking about the effect, it's talking about what to expect. Even if you don't think it's something, to still call your provider or call your doula. It's better to be safe than sorry.
Let's hear now an experience from one of the mothers who are with us today who experienced preeclampsia. Now, Liz, you're a first-time mom to Molly. Molly will be 2 years old in a few months. Now, you didn't have any family history with preeclampsia, but you did develop severe preeclampsia. Can you tell us your story and what some of your symptoms were?
Sure. So yeah, I didn't have, as you mentioned, no family history, no kind of risk factors except that it was my first pregnancy. At about 23 weeks, I developed kind of a really dull, throbbing headache. It was really kind of something I've never experienced before. Was also noticing some very mild vision changes. Obviously, I was only 23 weeks pregnant, so I had reached out to my OBGYN's office and kind of asked what are next steps. They said I could come in for a checkup. So I did have a blood pressure cuff at home and I checked my blood pressure and I noticed it was a little bit high. But after speaking with my provider on the phone, it sounded like it was very uncommon to have any issues as early as 23 weeks. But I ended up having a scheduled ultrasound that week, and the baby had completely dropped off the growth charts and fallen into the first percentile across the board. So they sent me to the hospital, and a week later, we couldn't keep the preeclampsia under control anymore, and she was born at 24 weeks and 4 days. We had about a week to prepare, so as you can imagine, we didn't have much done or ready to go, but such is life.
Thank you for sharing that with us, Liz. Dr. Gibson, I want to ask you some follow-up questions about that. So Liz mentioned that she had been told that it seemed kind of early to be experiencing those kind of symptoms. So when do preeclampsia symptoms, when can they present, and when do they typically present themselves?
Most cases of preeclampsia are later in pregnancy. So, Liz is right that she was early. But we can see preeclampsia as early as even 20 weeks of pregnancy. So that's why throughout the whole pregnancy, as we mentioned, talking with your healthcare provider, talking with your doula about what you're experiencing is so important, because even early in pregnancy, we can see preeclampsia. I also want to bring up, Liz had a blood pressure cuff at home, and here at Metro, we're giving blood pressure cuffs to patients who are at higher risk of preeclampsia, so that in between your visits, when you might get a headache or you feel something is different, that you have a blood pressure cuff readily available to be able to check. Really helps to empower our patients to be able to see what's going on with their bodies if they feel something different, and then have that piece of information. That blood pressure is so important for us as healthcare providers to then help to see what's going on with the patient, when they might be having to come in to be evaluated, or when they might be okay to stay at home.
If you're just joining us here on The Sound of Ideas, we are talking about preeclampsia, which is a high blood pressure pregnancy disorder. If you have comments or questions, you can give us a call at 866-578-0903. You can also send us an email at soi@ideastream.org, or you can send us a message on Instagram at The Sound of Ideas. Now, Dr. Gibson, Tane told us a bit about it, but can you break down for us as well some of the warning signs or the symptoms that a patient might have so that they can be on alert that they might need to get checked out?
Absolutely. So we've talked about blood pressure. So the blood pressure numbers that we look for in pregnancy are anything higher than 140/90 should kind of prompt a conversation with your healthcare team. Anything over 160/110 should mean that you're going into the hospital to be checked out. But there's other things we also watch for. So we heard the mention of a headache. So a headache that's not going away, especially if you're not someone who typically has headaches, that would be one warning sign. A change in your vision, so persistent blurry vision or dark black spots that are not going away. Chest pain, trouble breathing, or severe belly pain. Or for any time in pregnancy, once you start feeling the baby move regularly, if that changes or stops, that would be something else to come in for right away.
Is there something about the position of the belly pain, Dr. Gibson? In some of my reading, I had noticed that there's a mention about the top right side. Is that accurate?
You are correct. So right, we call it the right upper quadrant, or kind of just underneath the ribs on the right side. That's where your liver is. And what we watch for is actually, we talked about swelling in other places, but you can get swelling around the liver from preeclampsia, and that causes pain. So pain on that side is one of those warning signs to watch for.
Let's bring Tori into the conversation now. Tori, you also survived preeclampsia. This was during your pregnancy with your son, Miles. What were the warning signs that you noticed, and how did you end up eventually getting diagnosed?
Yeah, so throughout my entire pregnancy, I would say I worked out 4 days a week doing kickboxing. I've always had really low blood pressure, even to the point where some providers were like, this is a little too low, but that was also just my normal. Um, I started experiencing symptoms of just swelling, severe swelling in my legs, and it was around 28 weeks. And I kind of put it off originally as it's the middle of summer. It was the middle of the heat wave last July. And I'm like, I'm going into my third trimester. I must just be really like, I'm just been on my feet, just kind of putting it off there. But then something deep inside me was like, you need to check your blood pressure. And again, as someone who does not have a history of high blood pressure, that was really alarming to me. That week, actually, at 28 weeks, we ended up losing my husband's grandma, and someone that was very, very important to him in his life. And, so it was a very also stressful week as well. So some of the symptoms I was kind of putting off to some of that stress. But when I actually ended up testing, doing my blood pressure at home with a blood pressure cuff as well, I saw that it was very high, and I ended up calling my midwife's office, and they were like, hey, it's not high enough to go into the hospital at this point, but, try hydrating, putting your feet up, and then check it again in about an hour. And that's when it actually increased even more. So I actually went into the hospital to be monitored. And unfortunately, it wasn't my hospital that I typically go to or the network because I was out of town. So I would definitely say like the swelling of my legs and then that high blood pressure, I did start to feel, get some vision changes. But as someone with a history of also migraines, I also kind of put it off as that too. So those were the ones I would mainly that I've mainly experienced. And then I actually ended up being hospitalized at 28 weeks, and it would have been 5 days, and I ended up having my son on 29 weeks in 1 day, so only a couple days later. So again, not much to prepare. Very similar to our other mom as well, just especially having my first so early as well.
So it sounds like for both you, Tori, and Liz, things moved very quickly. So how were you feeling? Did you even have time to feel anything when you're getting this kind of a diagnosis and then moving so quickly into delivery?
Well, since I was actually, I was with my mom at that follow-up OB appointment where the OB actually said, you need to go to the hospital now. My husband wasn't with me and I just started crying, I'll be honest. I was scared. I had a lot of, why me, especially having such a healthy lifestyle? Like, why am I having this? And just fear in general of having a premature baby, knowing that he was going to be premature, whether it was that day or at 34 weeks, which was the goal for my team to get me to 34 weeks for an induction.
Liz, what about for you? Things moved very quickly for you. Were you aware of preeclampsia? How were you feeling when you got all of this information?
I really did not know much about preeclampsia at all. The only reason that I even knew headaches were associated with preeclampsia is because I saw an infographic online, similar to what Sound of Ideas posted earlier in the week, that headaches and some of these other vision changes can be associated. So that's the only kind of touch point that I had had with it. So I was kind of completely caught off guard as well, especially with how fast everything moved. There really kind of wasn't much time to process or prepare.
Did your team have a goal for you for keeping Molly, you know, in development, I guess,
cooking.
as long
Yes,
as possible?
They, honest to God, we were kind of just looking at things day by day at that point. We knew with how quickly things were progressing. I mean, they were honest with me up front that, we could be looking at one day, we could be looking at a couple weeks, but we're likely not looking at more than a couple of weeks. So ultimately, we were taking things kind of day by day, and it turned into hour by hour in those days leading up to her birth.
Dr. Gibson, we've talked a bit about risk factors. So can you explain to us what some of the risk factors are for preeclampsia?
Absolutely. So one common risk factor we've seen from our moms here is first-time pregnancy. So that's one of the biggest risk factors, being either young or older at the time of your pregnancy, a history of preeclampsia, either in yourself or in family members, or a history of high blood pressure, a history of diabetes or lupus. And then there's also some social factors that are really more based on social constructs than actual medical history, having to do with chronic stress. So having a lower socioeconomic status or being of Black race or other minority are also risk factors for developing preeclampsia.
That risk factor being a first-time pregnancy, there's nothing you can do about that. Everybody has to have a first-time pregnancy if you're going to have a child. Liz, aside from that, do any of these risk factors apply to you?
No, no other risk factors.
And how about for you, Tori? Any risk factors apply for you?
No, just the first time pregnant.
Okay. And Tane, I want to ask you, in your work as a doula and with Birthing Beautiful Communities, can you tell us, is there anything that your organizations are doing to help some of those stress factors that Dr. Gibson mentioned to try and reduce that risk?
So you have toxic stress, you have chronic stress, and you have weathering. And when it comes to weathering, especially as a Black person, you walk around as a person who is discriminated against on a regular basis. As the provider said, there are many other socioeconomic things that come into play. And so what we're doing in real time is interrupting those cycles. So let's take transportation, for instance. If you don't have transportation, then you risk not being able to make your doctor's appointments. If you live in a food desert, then you can't get to a grocery store. If you don't have transportation, it may impact your income because it may impact your job status. You may not have a job. So what we do in terms of making sure that you get to your doctor's appointments and making sure that you have transportation to get to a grocery store is we provide Ubers. If your insurance company doesn't provide an Uber, we make sure that we provide that Uber for you to make sure that you don't miss any appointments, to make sure that somebody is accompanying you also at that appointment, to make sure that we're advocating. So we are interrupting cycles in real time when it comes to social determinants of health.
If you're just joining us here on The Sound of Ideas, we're talking about preeclampsia. We're talking about the risk factors for it and the results that can come from it. It can be serious. It can be deadly for both mother and baby. If you have something you'd like to contribute to the conversation, you can call in at 866-578-0903. You can also email us at soi@ideastream.org or send us a message on Instagram at The Sound of Ideas. We have a call now from Melissa in Bainbridge. Hi, Melissa. Welcome to the show. Please go ahead.
Thank you. My incident took place in 1979, first-time pregnancy. That's the only risk factor that I had. My water broke. I'm in the hospital, and I developed preeclampsia then, not prior to going into labor. But to compound the problem, my labor was stalled. So the two medications that they give to you, at least at the time, counteracted each other.
Oh.
So I was in labor for 22 hours, and looking back, I'm surprised they didn't give me a C-section, but they didn't. And everything turned out all right. The baby was fine. I was worn out, but I was fine. So that's my story.
Melissa, can
Having-
I ask you, how far along were you into the pregnancy when this happened?
Oh, sure. Let's see. He was born 2.5 weeks early, but I think that was not considered premature birth at the time.
Okay.
So,
Okay. Thank you for sharing that with us, Melissa. We appreciate it. Dr. Gibson, I want to ask you a follow-up to what Melissa just shared there very quickly. Is that something that's common that happens, preeclampsia, to begin in the midst of labor?
It is. And, our stories here today from our moms happening at 24 and 28 weeks are not the typical. I think this last caller is a little more common in that we see most preeclampsia at term. She sounds like around 37, 38 weeks of pregnancy, which is full term. And that's often a story. Someone comes in, and as we're evaluating them, maybe for their water breaking or contractions, we notice that their blood pressures are high, and then we do some other tests and often make that diagnosis at that time.
Okay. Thank you very much, Dr. Gibson. We have a call coming in now from Solon. It's Carla. Carla, welcome to the Sound of Ideas. Please go ahead.
Okay, thank you. My first pregnancy back in 1994, I just went in for a routine visit and found out that my blood pressure, I just remember the top number being 200, but I felt fine, but I always had headaches. I think your guest said that. So it didn't bother me because I always had headaches. And I just, then that's when I was told I had preeclampsia. But the doctor told me, just said, go home and lay on my left side I was 8 months pregnant, just lay on my left side for a month to finish out my pregnancy. And then I just went in for the routine, visits for the remainder of my pregnancy. And my blood pressure did go down, and I just managed my diet. But, and that was it. I just had to lay on my left side. So I always wondered, what was the point of that? But it worked.
Mm-hmm.
Yeah.
And Carla, you were about 8 months pregnant at the time. This was in the early 90s. Is that what you said?
Yeah, 1990. My son was born in 94, yes.
Okay. Dr. Gibson, do you have any insight into that, why someone might be told to lay on their left side in a situation like that?
So I think some things may have changed since the 90s, but we know that, positioning can affect blood pressure. When we do check blood pressure, ideally a patient's kind of sitting, with their both feet on the floor, arms at rest next to them. But in general, if someone had a blood pressure up to the 200s in the office, I think the recommendation now would not necessarily be to go home and lay down, but to come into the hospital for evaluation. And sometimes a blood pressure reading could be off. Maybe that happened in the office, but we would want to get more information, evaluate it. I think both of our moms today that called in or that are on the show mentioned they had blood pressure cuffs at home, so that we can continue getting that information, and we would want to evaluate that right away.
Tane, what do you think about that?
I think more often than not, we don't want to believe, but we have to believe because it's happening, that our moms are dismissed. And that's what it sounds like with that particular case. And we have a client right now who had preeclampsia toward the end of pregnancy, like very end, right before delivery. And she was on the magnesium drip. In my opinion, she went home a little too soon. But 8 hours later, she ended up back in the ER. And she had reported having a headache before she left, reported not feeling right before she left. And the nurse that she had said to her, well, I'm sure you'll feel better once you get home to your little ones. So 8 hours later, she's back in the ER with 177 over 100 blood pressure, headaches, pain under the right side, blurred vision, just all of those classic signs after delivering her baby. So her baby was 4 days old once she was discharged, and she ended up back, but the ambulance took her to another system. And she ended up staying in the hospital for 5 days, released, and back again the next day because her blood pressure was uncontrolled. So had she not called me at 4:30 in the morning to say, hey, something's not right, I don't feel right. And had I not said immediately when she told me her blood pressures, call 911, you have to go back, this is severe. So the trust is built, but oftentimes as Black women, we are dismissed. And education is not enough if the systems are not responding properly.
Dr. Gibson, something that Tane mentioned there was the magnesium drip, which is a treatment that can be given when you're in the hospital for preeclampsia, magnesium sulfate. Can you explain that to us?
So magnesium is given to lower the risk of having the seizures, the eclampsia. There have been many studies, some using seizure medicines used for things like epilepsy. And of all of those different medications, the magnesium works the best to prevent eclamptic seizures, which we know are due to swelling around the brain, a little bit different process than other types of seizures. So that is a standard medication that's used in cases where the preeclampsia is severe.
And I understand it's not a pleasant experience, the magnesium drip. Can you tell us a little bit about how it impacts someone who might have to have that, Dr. Gibson?
Yeah, you're correct. It makes makes patients feel kind of hot, sometimes groggy, and sometimes patients report kind of like just a foggy brain from the magnesium. We know that it's not the most pleasant, but we also know that in cases where the blood pressures are that high, that it's needed to lower the risk from having those seizures.
Does it help the baby at all, or is this strictly for mom?
So in cases where a patient is less than 32 weeks, the magnesium does also help lower the risk for cerebral palsy, which is a risk when babies are born very early. So the magnesium in those cases does kind of serve two benefits. One for that what we call neuroprotection to reduce the risk for cerebral palsy, and then one to prevent seizures in mom.
Tori, did you have to be on a magnesium drip?
Yes, I was actually on it for 12 hours when I was first admitted. And it was a horrible experience for me, but I'm happy that I got it just because of how high my blood pressure was. And then when I ended up having my emergency C-section, I was on it for 24 hours.
That's a long time. Well, Liz, what about you? Did you have to be on a magnesium drip?
Yeah, similar experience to Tori. I was on it prior, about 24 hours leading up to my emergency C-section, as they tried to keep my blood pressure under control. And then I believe like another 24 hours afterwards.
Okay. And did you have similar reaction to that? Did you have the hotness, the grogginess, those kinds of feelings, Liz?
Yeah, very much so. Lots of flushing. I had a lot of muscle weakness and kind of like confusion with it. I definitely wasn't totally with it while I was on the magnesium drip, but similar to Tori, I'm glad that I had the opportunity to take it.
Okay. If you're just joining us now on The Sound of Ideas, we're talking about preeclampsia, which is a high blood pressure pregnancy disorder. It's serious and can sometimes be deadly for mother and for baby. We will be taking calls on this when we come back after a quick break here. The number is 866-578-0903. You can also email us at soi@ideastream.org or send us a message on Instagram at The Sound of Ideas. And when we come back from the break, we'll talk about how an existing treatment for high-risk cases is now being thought about differently for preeclampsia. This is The Sound of Ideas. I'm Stephanie Haney. We'll be right back. Welcome back to The Sound of Ideas. I'm Stephanie Haney. Thanks for staying with us. Today we're talking about preeclampsia. This is a high blood pressure pregnancy disorder. It affects 1 in 12 pregnancies in the U.S. and in the worst cases can lead to death for both mother and baby. Those are the worst cases. We're talking about it today with a panel of people, including 2 moms who experienced preeclampsia. That's Tori McGinnis and Liz McCray. We also have medical professionals with us. We've got Tane Bolton, Senior Director, Strategy and Engagement for Birthing Beautiful Communities, and a full spectrum doula, also a certified diversity practitioner with us in studio. And then joining us on video call, we have Dr. Kelly Gibson, the Division Director of Maternal Fetal Medicine at Metro Health. If you want to be a part of this conversation, the number to call is 866-578-0903. You can also send us an email at soi@ideastream.org, or you can send us a message on Instagram at The Sound of Ideas. We had a call in from Todd earlier. Todd couldn't stay on the line, but wanted to ask about whether preeclampsia can be prevented or aspects of it can be prevented with any sort of medication ahead of complications. Which brings me to a question for Dr. Gibson as we talk about awareness of this complication, but maybe changes in protocol that could help reduce risk. Dr. Gibson, can you tell us about any changes that have been happening recently?
Yes. So that's a great question from Todd. So there's kind of two things that I think about to lower the risk for preeclampsia. The first is for patients that have high blood pressure outside of pregnancy, or what we call chronic hypertension. We know that treatment of hypertension to a goal of less than 140/90 can lower their risk for complications. So that's one group. But as we've heard from multiple callers and our other guests today, some patients don't have any of those risk factors. And so the other treatments that we have that we recommend now at Metro Health and actually across the city of Cleveland universally is a low-dose aspirin. Aspirin's been used for a long time for prevention of heart disease later in life, but we found that it also lowers the risk for especially severe forms of preeclampsia when taken daily throughout pregnancy. So we recommend 81 to 162 milligrams each day.
Okay. And Liz, were you told to take low-dose low-dose aspirin during your pregnancy?
I wasn't, but at the time, I believe the protocol with my provider was that only individuals that had a high risk factor took the low dose aspirin.
Okay. And Tori, how about for you? Were you told to take low-dose aspirin during your pregnancy?
Yes, actually, my midwife told me about it when I was probably about 8 weeks, and she told me to started it at 12 weeks, so right outside of that first trimester, and I did. As soon as I hit 12 weeks, I was taking my one baby aspirin every single day.
Dr. Gibson, why do you think it's taken until now for this medication to be recommended universally here in our area?
Actually, nationally, it's still recommended for risk factor based assessment. So we heard some of those risk factors earlier. Here across the city of Cleveland, we know that Cleveland has not the best statistics for moms who are pregnant. And so through what's called First Year Cleveland, which is a collaborative work between all the healthcare systems as well as several community-based systems in Cleveland. We're looking for ways to reduce the risk of maternal morbidity and mortality, also infant mortality. And because preeclampsia is tied to all of these things, we, as a kind of a citywide effort, decided to recommend aspirin for all patients, because some patients, their only risk factor is being pregnant. And we want to ensure that everyone has the potential to benefit from the additional use of aspirin.
Do we know anything, Dr. Gibson, about how effective it is having people universally in a first pregnancy or with that risk factor of being pregnant taking the low-dose aspirin?
So there are a few smaller studies, not from our city, but from other cities, including some in Texas, that did show a benefit by saying everyone should take aspirin in terms of lowering the overall rate of preeclampsia in the community.
We have an email question now from Laura. Laura asks, is preeclampsia genetic? In other words, if my mother had it, am I likely to have it during my first pregnancy? Any idea about that, Dr. Gibson?
So it does, it's another one of those risk factors, and risk factors don't guarantee that you'll have that condition. It does mean that you're at a little higher risk. So certainly something to talk with your OB provider about, maybe have a blood pressure cuff at home, take that low dose aspirin, be listening to what your body is telling you throughout pregnancy. If you're feeling something different, to come in and be checked out.
We have a call now from Marianne in Huron. Marianne, please go ahead. Welcome to the Sound of Ideas.
Oh, good morning. Thank you. So interesting. I was a nurse for 44 years, and there were two things I was aware of, and it was that the black women did have prenatal preeclampsia and high blood pressure. But the thing that I never knew, and I learned through experience, is that a lot of women who are thin, and a lot of these women were thin. They were very thin. They're not overweight, and that's another prejudice. We have a prejudice against, well, in general, like heavy-set people, and we assume they're going to be the sicker one. And I used to sometimes have to use a adolescent pump on these women, and their blood pressures were over 200. I was like astounded, and that is something that nobody would be aware of, but I saw that pattern. And the second question I had is this: I had a placenta abruptio at 34 weeks, and the baby lived for like 7 hours, and then she died. But is there any preeclampsia, or I had no signs with prenatal care that would show? Is there any relationship between those two things? And thank you very much. This is very interesting. It's very important.
Marianne, thank you for calling in. I'm going to ask you if you can repeat the question about what it was that was experienced at 34 weeks. I had a hard time making that out.
Placenta abruptio, where the placenta detached,
Okay.
and then the baby delivered, and then lived 7 hours and died. But that was 40 years ago, so I know things have changed.
And this was something that you experienced or something that you saw as a nurse?
Something that I experienced. And
Okay. Thank you for sharing that, Marianne. Dr. Gibson, is there any insight you can share there about the placental separation and if that may have had anything to do with preeclampsia at 34 weeks?
Yeah, it's a great question. And I'm sorry to hear that you went through that. So a placental abruption is where there's bleeding behind the placenta and actually separates the placenta from the wall of the uterus. A small abruption, sometimes we can manage and everyone can be okay. A large abruption can actually separate the placenta sometimes entirely, because the placenta is how the baby is getting oxygen and nutrients. If it's separated, that can even be a cause of a stillbirth. We also know that preeclampsia, high blood pressure are risk factors for a placental abruption, so the two can go together. An abruption can happen for other reasons, but a common reason is related to high blood pressure. And so that's one of the things as we're evaluating both of our patients. One of the things that I worry about is, could there be bleeding behind the placenta? Could that affect how well the placenta is developing, how the baby is growing? I know one of our moms on the line said her baby was growing very small, and that probably also has to do with the blood flow to the placenta. May not be an abruption, but it's still affecting how well that placenta is growing. So the two can certainly be related.
I'm going to share an email now that came in to the Sound of Ideas. This is something that came in over the Instagram account and then also via email. This is from Tony, and we have been talking about preeclampsia cases where the mothers did survive and the babies did survive. This is a different situation, so I want to prepare people for that if you're joining us here on the Sound of Ideas as we talk about preeclampsia. Tony writes in, at my routine checkup when I was 30 weeks pregnant, my blood pressure was slightly up, there was protein in my urine, and then my midwife couldn't find a heartbeat, even with a second machine. I was rushed to an emergency ultrasound, which showed that my baby had died. Someone took my vitals, my blood pressure had shot up to 180 over 120. I was having a hypertensive crisis. They started tying pillows to my bed rails in case I began to seize. My husband only half understood what was going on. I looked at him and wondered if he'd be leaving this hospital alone. I knew I could die, but I was worried about him. 36 hours later, my son Calvin was born still. I was alive, but I so easily might not have been. My labor had been induced because the only way to cure preeclampsia is to deliver the baby, and my preeclampsia was ferocious. Until that morning, I hadn't had any of the most common symptoms of preeclampsia, but I'd been feeling off for a couple weeks. I even went to the hospital once because I was dehydrated from vomiting. My blood pressure was normal then. We eventually found that Calvin had probably died nearly a week before my checkup. My blood pressure had probably been spiking like it did in the ultrasound room. A severe enough spike or series of them made the placenta detach from my uterus. That was 25 years ago. I've had 2 subsequent living children. Both pregnancies were high risk and intensely monitored. Both were perfectly normal. Losing Calvin changed my life utterly. So did seeing my own mortality. I'm one of the lucky ones. Tony, thank you very much for sharing that story with us. And Tane, I want to ask you, we've been talking about these cases. These are severe cases we're talking about. Obviously, that's an incredibly severe case. How often do you see the cases that are on the severe side? How often are these stories the stories that are coming through?
Unfortunately, these stories come through a lot. We do see the severe cases of preeclampsia, which is unfortunate, but we have not lost a mom. So that's the fortunate part, that our care and our advocacy and making sure that these moms are cared for shows, because we haven't lost anyone.
Dr. Gibson, can you give us some context into how often preeclampsia cases become the most severe?
So they are not the most common, but especially for me as a high risk doctor, we see those most severe cases. So while the majority of preeclampsia, it affects up to 12% of pregnancies, those that are this severe are a very small percentage of that. But for us, losing one mom or one baby is one too many. And so that's why we want to get the word out about what to watch for, why we're working citywide to try and come up with collaborative ideas that we can do as healthcare systems and as community organizations to help empower patients, to listen to our patients so that they don't get dismissed when they come in and that they are heard. Because we know that we can't, unfortunately, prevent every poor outcome, but we can work really hard and try.
Tori, can you tell us how long were you in the hospital being treated for preeclampsia?
So it's funny, you remember the dates and like some of those fine details even when things are going so fast. I was admitted on July 29th, and then I ended up having my son on August 2nd. So I was only there for a few days. And that email that you read, it definitely really stood out to me, because especially the line of knowing your own mortality, because I definitely felt that, and I still feel that today because I ended up having one of those severe cases with an abruption. And that's ultimately why my son was delivered so early. So I was only there for a few days, which again is not what we planned. We were planning for 34 weeks and being induced and everything, but obviously things were different.
Liz, how long were you in the hospital, and what were those feelings like, that uncertainty? I know you said it was day to day, it was hour to hour there at some points.
Yeah, so I was in, similar to Tori, less than a week, and ironically, Molly was born on August 2nd as well. And then I stayed for about 6 days afterwards, because I had some residual, or about 5 days afterwards, I had some residual preeclampsia symptoms that I needed to get under control. And then obviously, just being born so early, Molly had about a 6-month NICU stay after the fact. But yeah, it was definitely a long road.
How's Molly doing now? We're about a year and a half later from this for Molly. How is she?
She's doing very well. Thanks for asking. She, obviously being born at 24 weeks, and with the preeclampsia side of things, she was born the size of a 22-weeker. So she was just under 500 grams, little less weight-wise than a water bottle, a full water bottle, which is wild. But now she's almost 19 pounds, still in the first percentile. She does have some continuing complications from prematurity that we're going to be dealing with throughout her life, but she's defied every odd. So we're very, very, very fortunate.
And cute as a button. If you were watching us on the Ohio Channel or the IdeaStream Public Media YouTube page, you just saw some pictures of Molly. Tori, how is Miles? How's Miles doing?
He's doing amazing. Even with having a 3-month stay exactly in the NICU, having some complications that required some very serious conversations early on, which again, it's a first time parent, you don't expect to be having those conversations. But he's doing amazing. We actually just had we did his 9-month checkup actually a little early. We did it yesterday. And he is ahead of his adjusted age of about 6 months, but slightly behind on the 9 month, but exactly where the pediatrician wants him to be. And again, similar to Molly, he'll have some long-term effects, especially with his breathing, which we're dealing with right now with an upper respiratory infection. But overall, like, you wouldn't even know unless if you actually knew our story, just how he is.
And Miles, also adorable. Looks like Miles has a little furry best friend that we saw in some of those pictures. If you're not checking us out on the Ohio Channel and the IdeaStream Public Media YouTube page or on social media at The Sound of Ideas, I recommend you do that because there are cute babies that you can look at if you do that. We have a call now from Beth in Madison. Beth, welcome to The Sound of Ideas. Go ahead.
Good morning. It has been fascinating to listen. I experienced all this as a new mom, new wife at 19, and I'm thankful to tell everyone that everybody is fine. We also have had prematurity with a couple of grandchildren as well, one severe, one not quite as much. My question comes because my experience has been, we've already heard it 3 or 4 times, which is wonderful. But what is recommended now for subsequent births? I know for me, back in the 1980s, with my second son, I was given a salt-free diet for the final 3 months.
A salt-free diet, did you say, Beth?
Yes, salt-free for the final 3 months, which I know now that's probably not the way to go because salt is so important. And he was born full-term, VBAC, healthy, and so on. But what is recommended now for those going into a second pregnancy after having such a traumatic first one with eclampsia and preeclampsia?
Thank you for the question there. And VBAC, for those who aren't aware, that's vaginal birth after cesarean section. So Dr. Gibson, can you please address what Beth was asking there?
A great question, Beth. And I wish I had more things to say, but right now the recommendations that would not include a low salt diet, but would include the low dose aspirin, would include having a blood pressure cuff at home, so frequent blood pressure checks. And then would also include, I would advocate for having a doula, having a trusted birth team, including your provider and other medical staff who are there to help listen to you, advocate for you, and hopefully also reduce some of the stress as best we can during the 9 months of the pregnancy. There's ongoing research for other things that we can do. So I'd put a plug in to support medical research, especially in pregnancy, which is often underfunded, so that we can have more options for things to offer patients if they have a history of preeclampsia.
One of the risk factors we did talk about is having preeclampsia the first time around. So if you don't mind sharing, Tori and Liz, I'll ask you both. And Tori, I'll start with you. Do you plan on having a second pregnancy?
Yes, we would love to expand our family. We wanted to have a little bit of a closer age gap, but due to me almost with the abruption, almost losing my life, and then ultimately, or almost losing Miles, not only just with the birth, but with those complications after he was born. We're going to wait at least a couple years, allow myself to heal both mentally and physically from the C-section before we hopefully have that trial of labor and hopefully a better outcome in our pregnancy or in my pregnancy. Plus, I know our family would love to have more little ones as well. So we ultimately do, yes, but in due time as well.
How about for you, Liz?
Something I wish I could give you an answer to, but we're not 100% sure yet. We're kind of working through the process. I've had a few consults with maternal fetal medicine. I've met with preventative cardiology. I've met with rheumatology. We're kind of trying to check all of the boxes that we can prior to considering a pregnancy in the future, just to make sure to kind of queue us up in the best position. And I know it's a really kind of difficult thing to navigate, and I know a lot of moms are in kind of the same boat. So I just want to add a quick plug. I'm in a group called Project NICU. I know a lot of babies born from preeclampsia end up in the NICU, and they have a Preeclampsia and Help virtual parent group. It's held the first Thursday of every month at 8:30 p.m. And so many of the moms are in the kind of the same boat of navigating these uncertainties. And it's a great resource, and it's a great place just to kind of for moms to share where they're at.
Okay. Thank you so much for sharing that, Liz, and for recommending Project NICU. We'll also have links to Birthing Beautiful Communities and other resources. You can find those at ideastream.org/SOI. I want to thank our guests for participating today. Joining us virtually, we had mothers Liz McCray and Tori McGinnis. Liz and Tori, thanks for being with us.
Thank you.
Thank you.
Also virtually, we had Dr. Kelly Gibson, the Divisional Director of Maternal Fetal Medicine and Metro Health. Thank you so much, Dr. Gibson.
Thanks. Pleasure to be here.
And here in studio, Tane Bolton, Senior Director, Strategy and Engagement with Birthing Beautiful Communities and Full Spectrum Doula and a Certified Diversity Practitioner. Thank you so much, Tane.
Thank you. Glad to be here.
If you missed any part of today's show, you can hear a rebroadcast tonight at 9 on 89.7 WKSU, and you can find every episode of The Sound of Ideas wherever you get your podcasts and on the IdeaStream Public Media YouTube page. If you want to get the last word on today's topics, you can email us at soi@ideastream.org. You can also send us a message on Instagram. We're at The Sound of Ideas. Yesterday, we had conversations about the labor landscape here in Northeast Ohio. Chris wrote in, as an employment lawyer who represents employees, we sometimes see the downside of a unionized workplace. Sometimes the interests of the union diverge from the interests of an individual employee navigating the grievance process. Often workers perceive that the union isn't protecting them when the union won't pursue a grievance or arbitration, and often the union is acting in the interest of itself and its relationship with the employer. Thank you for sharing the perspective, Chris. We appreciate it. Tomorrow on The Sound of Ideas, we'll talk about Northeast Ohio social groups helping young people make friends and potentially find love. We hope that you'll join us then. I'm Stephanie Haney. Thanks for keeping the conversation going. We'll see you tomorrow.